Good evening to all of our audience tonight. And today's show has been brought to you by Evrock Healthcare, which is a digital healthcare company, and its flagship product is the F1 app. Today's topic that we would be covering is palliative care. This show has been brought to you by the company which also owns a very good series called as Mind Matters, in which we bring such topics related to mental health as well as other topics that actually are stigmatized and tabooed and not much talked about. So today, now that we have a palliative care doctor and specialist amongst us, his career was marked by developing and implementing hospital-wide policies, procedures, and protocols that improve patient access, patient compliance, regulatory compliance, and hospital efficiencies. He is a department operations management person, and he has done his regulatory, corporate, and joint commission compliance, his professional practice hospital policy, protocol and procedure development, EMR system implementations, patient access and satisfaction, physician relations, staffing and training and developing resident and medical student training programs. So he is also the director of Vayodhya's Long-Term Care Hospital, which is based in Nagpur. Please welcome Dr. Ravi Wankhede.
Good evening, all. Greetings to everyone.
Okay, Dr. Ravi, your screen is a bit frozen, but we can still hear you, I guess.
Okay.
Okay. So welcome to the show, and thank you for accepting our invitation based on palliative care. And not much people talk about palliative care. So thank you for coming. And also thank you for doing what you're doing in the city of Nagpur. So beginning with the topic, what is basically palliation? So most of the people don't know what it is. So let's talk about it. What is the definition of palliation and what does it mean?
Well, first of all, thanks for having me. It's an honor to talk about palliation, especially when not many people understand what palliation is, or for that matter, how different that is from hospice or F-like care. So, a palliation is defined as basically taking care of a person with chronic illness or a condition which is untreatable, alleviate the symptoms, hence adding quality years to the life. That's a precise, a definition for palliation.
All right. So basically, what generally people understand from palliation is that it's a cliche that it's only for cancer patients or only for terminally sick patients and other patients suffering from very high end diseases. So what is your take on that? What is it basically used for?
Well, that's a cliche actually, that palliation is only required by cancer patients or cancer third stage patient. Actually, palliation can be required by a person with, say, heart failure or a chronic kidney disease patient, or for that matter, Alzheimer's or Parkinson's, a low-level stroke. Those patients, they all require palliation at some point or the other. So what happens is that when you diagnose a person with a condition or a chronic illness, palliation actually starts right at that minute, and you can get maximum out of palliation when earlier, if you catch that person in earlier stages. So making their life more comfortable.
Okay, so you just said that the palliative care should be offered right at the moment a chronic disease has been diagnosed in a patient, right? So what all do we
Correct.
start offering, and in what all stages do we start offering that in palliation?
As soon as a chronic
Could you hear me?
disease
Okay, yeah.
is diagnosed, that's when immediately palliation needs to be started.
Yes, yes. So what
So
are these stages like? Say, for
when
example, if
palliation, I'm
okay,
sorry,
sorry, actually you are freezing in between, so I'm not able to grasp
I'm
the
sorry, I
situation
think some
as of the
issues
moment.
with net connections, I guess.
Okay, please continue. We can hear you.
So I apologize. There's some issue with the internet connection. But palliation not only, I mean, it's not, palliation is a multidisciplinary process. When I say a person, when a patient is diagnosed with chronic illness or a diagnosis which is untreatable, so there needs to be so many different disciplines which need which gets included or get involved in treating that patient. You being a psychiatrist, you probably understand the anxiety level and the hopelessness of the patient when they're diagnosed with such conditions. Apart from that, they do carry a burden of, say, financial responsibility towards their family. They might have a spouse, they might have kids who needs to be taken care of. So all those decisions, all those discussions needs to happen as soon as the person is diagnosed with a chronic illness or a condition which is untreatable. Hence, I say a palliation treatment should start as soon as they're diagnosed with such conditions.
Okay, so what are the different aspects that are offered in palliative care?
So basically, palliation. The first thing which needs to be done is screening and identification of such patients. Second most is the triage, where all and every aspect of that patient needs to be collected, and then a comprehensive assessment needs to be done for that patient. Followed by comprehensive assessment is a care plan. Then after you're done with the care plan, one open and respectful actually communication needs to be started with the patient and the family. Then of course the symptom alleviation which needs to be done. The most important which needs to be done is 20 to have them available at 24/7, a support system available, which can actually, release their anxiety and maybe a symptom which can be treated at the right at the time.
Okay, so when we talk about this, there are a lot of chronic illnesses that can come under palliation, right? So that means a lot of other streams are involved, a lot of other doctors are involved in this, or only people who are palliation specialists.
So yes, there are lots of disciplines involved in this. Initially, the primary care provider or the doctor who diagnoses the patient with condition or the disease. Secondly, a clinical psychologist or a psychiatrist, they need to be involved, to identify the emotional issues or the reasons behind depression. Thirdly, the caretaker, the primary caregiver needs to be involved. Apart that, if patient, for XYZ reasons is experiencing pain, then people who can manage their pain with pharmacological aspect, non-pharmacological aspect needs to be involved. So it's definitely a multidisciplinary process when it comes to palliation.
All right, all right. So you mean to say that if somebody is, on dialysis, so obviously the nephrologist will also be involved, and if somebody is having a
Correct.
cardiac issue, obviously the cardiologist will be involved. If somebody is having a stroke, then the neurologist will be involved. And obviously, in every
Correct.
aspect, the palliative care doctor as well as the psychiatrists are involved. Yeah, so speaking a little
Correct.
about psychiatry and palliation, I'd like to mention certain things that a lot of people who are undergoing palliation suffer from depression, suffer from high levels of anxiety, And during that moment, obviously, referring those patients to a psychiatrist is very important. Also, when they are in the ICU, and again, when they are admitted with end of life care, um, they have similar issues, and their relatives are going through grief. Their relatives are almost about to start mourning because of the bereavement that is going to come. So in all of these things, I think a psychiatrist and a psychologist's involvement is very, very important. So that's to be noted. And yeah, so when we talk about palliation, we also confuse a lot in, we call it end of life care also, which is not true, right? So what is the difference in between end of life care and palliative care?
So palliation, basically palliation care, it doesn't have to that a patient who doesn't it's not necessarily be dying after palliation can, but if a person is having, say, for maybe around 5 to 6 months of life expectancy, those patients are more of a hospice life patient. Palliation as such whole, I mean, it treats person as such whole, not only symptoms. When it comes to psychological, comes to social, there may be stigma involved. Say if there is an HIV patient, there may be, I mean, even for stroke patient, there is stigma involved. There may be family issues, there may be financial issues for the matter. So when it comes to palliation, it deals with all this complete umbrella of issues. But end of life is basically making patient more comfortable. Or maybe it may be for pain, it may be for say simple use, or simply providing them with oxygen support. So this is a basic difference between hospice or end of life care and palliation.
Okay, so basically, end of life care is a part of palliation. Palliation is not a part of end of life care, is
Correct.
what I
Correct.
understood from what. Yeah.
Correct.
Okay. Okay. Right. Right. So, what do we offer in end of life care? Like just as you mentioned, maybe the pain management or the other. So, what all is included in that? What more can be done?
So I'll give you one example. I had one of this patient was CKD, chronic kidney disease, and patient had another comorbid condition of congestive cardiac failure. Her ejection fraction was around 15%, and she refused to undergo anything else, any other treatment, and she was ready to pass over to afterlife. And then the patient was referred to me. When she was
Okay.
referred to me, she was hardly mobile. But as soon as we started the care, she was diagnosed with UTI. So, was just to make her feel comfortable, that UTI was treated. But meanwhile, her oxygen level and the toxic level started to rise as well. So, providing with the oxygen support and the pain which she was experiencing, so we had to start her on a little bit of morphine and fentanyl patch, and maybe in 3.5 weeks, she passed away. And constantly giving her repositioning, prevented her from having any bed sores, and she passed away after 3.5 weeks with dignity and comfort. The family was happy, where the patient didn't suffer much, and because they couldn't see the pain because of pharmacological and non-pharmacological interventions. So that's end of life or hospice.
Okay. Right. And then the audience would also like to know what is DNR and when can it be signed and is it allowed in India?
Yes, DNR is an important. DNR stands for Do Not Resuscitate. So
Okay.
when I say that patient, when we identify and screen and identify those patients who requires palliation, these are the things which needs to be talked about in a respectful manner, so the treatment can be aligned with the outcomes according to their wishes. Say DNR is do not resuscitate. So if patient any issues, say patient gets a heart attack and or a cardiac arrest, so they shouldn't be revived and should let go. That's what the DNR is. And I was talking to patients with these possibilities, depending on their condition, is very that what exactly they wish for. Do they wish to be revived and put on life support system and extend the life further, or they should let go and getting out of this condition? So that's DNR, which they actually write it out and sign it with witnesses. It's a legal document. So that's what DNR is.
And is it legal in India?
I'm sorry.
Yeah, is it legal in India? Is it done in India as well?
Yes, it is. It is. Here in hospital, they call it DAMA. So that's discharge against medical advice, and pretty much that they cover everything.
Okay. Also, you must be seeing a lot of patients who are having palliative care or are in the ICU, undergoing a lot of ICU psychosis and delirium a lot of times. So, how do you deal with that? First of all, what is ICU psychosis?
So,
What is delirium? And how do you deal with that? Yeah.
so post COVID, actually, we did post COVID palliation as well, and we successfully discharged those patients back home, taking removing their oxygen dependency and stuff. So what had happened? Yes, we did get those patients with ICU psychosis and delirium. And in ICU, pretty much, unfortunately, every single molecule available, they are being put on. And that's where I guess people like you, a psychiatrist, they come in, where they streamline the medications and they try to wean them off of unnecessary molecules and make stable them on certain molecules, and hence their psychosis and delirium is addressed. So definitely a psychiatrist plays an important role in palliation, especially when patient comes out of ICU and comes for palliation.
Okay. And another question would be like, a lot of people, a lot of patients are losing hope when they are in palliative care. So, how do you basically motivate them? How do you try to help them in a way that they should be taking more and more palliative care?
So, important aspect to address and understand is their religious denominations.
Yeah,
Back
very
in
important.
states, yes, back in states, we used to do that. In India, I have started doing that as soon as I started at working here. Back in states, we used to have this denomination called Jehovah's Witness. I don't know if I'm pronouncing it right. So those are the patient who will not take any blood transfusion, even if
Right,
they
right.
die.
I've
So
seen that in Grey's Anatomy, I think, or maybe in House MD, somewhere. Yeah.
you probably saw that in Chicago Med. Uh,
No, I think it was Grey's Anatomy. But yeah, anyway, yeah.
yeah, yeah. So, anyways, here in India, what I saw was there was this patient with very lower level stroke, ischemic stroke, and the patient was in comatose. The patient was comatose for maybe say 15 days, and then they came to us. We never regained the consciousness completely. They were ready for the patient to, pass on to afterlife. Then they were very demanding of saying that, well, our mom is going to pass away, so we wanted to go dan, and there were certain pools as to do. Well, it's a hospital, so we couldn't do that, but we had to find a middle way where they could have something touched their mom, and they would, outside the hospital, they would do the ritual, whatever needed to be done. They were happy with it. And once those rituals were finished, within a couple hours, their mom passed away. That's when I realized that how important, religious denominations and their beliefs are to for these people to be relieved that they did what they did to their loved ones when they are passing away, going away. So yes, I hope I answered your question, right?
Yeah. Okay. So now talking about comatose patients, I think it is very important in palliation. So how do you manage patients who are, say, for example, in a coma for maybe 3 days, and compared to another patient who is probably in coma for maybe 2 years or more? So how does the management differ?
First of all, depending on the condition, how they are fed, even a comatose patient needs to be fed. So if it's TPN, total parenteral nutrition, or they're fed through a nasogastric tube, that needs to be determined. And if they're on oxygen or a ventilator, how, excuse me, how repositioning would be done, how their bathing would be done, how their hygiene would be maintained. These are the important aspect which needs to be focused, because fortunately, if these kind of patients they wake up, they need to be in a better position without any bed sores or without any bacterial or skin infection. So yes, hygiene and a trained nursing staff would reposition them every so many hours, and the hygiene, regular hygiene, which needs to be maintained, it needs to be followed for a patient who's in
Yes. So
coma for 6 months more.
yeah. So speaking of hygiene, also, there are a lot of concerns when it comes to the catheterization of a patient. So how do you manage the catheterization in such patients who cannot move, who cannot go to the
Uh,
toilet?
Yeah, that's always been a challenge. That's always been a challenge. So we follow the protocol which American Geriatric Association, put it in place, that if you're using a catheter, then it can be replaced every so often, and it needs to be dated and timed, and replaced accordingly. What our protocol demands or recommends.
All right. So, who are the other specialists in your team when it comes to palliation? And also, like, if there is a patient under palliative care, how do you all manage them together? Like, does it pose a challenge? Do you have different opinions? And if so, then how do you manage them?
I'm sorry, I didn't hear the first part of the question.
So in palliation, we have a team of doctors working together, right? So you must be having a lot of difference of opinions. So a lot of differences must be there, and maybe your opinion, maybe somebody else's opinion. So how do you manage that?
So that's always, agreeing to disagreeing between professionals. There are many times, but you always have to, look for patient's benefit. That's the first thing. I believe, we as a clinician, we have to have all the options on the table, and pros and cons of those opinions as well, those options as well. And that's when patient's relative or patient's caregiver, whoever the next one is, they help us make the decision that, okay, this is what I'm gonna go with, and accordingly we make the decision.
Okay. Did you want to say something else? Okay, there is a
No,
question.
I think I thought that I almost lost you. That's why I was kind of checking that, yeah, if I'm
Yeah,
still.
We also thought so because the screen got frozen. Okay, please continue with what you were saying.
So yes, when I said patients next to kin is the one where we keep all the options and pros and cons of those options or decisions of different doctors or professionals. And then next to kin, a patient next to kin, they are responsible to make that decision, and we go by the decision.
All right, there was a question. Admin, you can flash it. Are life-saving procedures like tracheostomy or intubation included in palliative care?
Yes, yes, they are. They are. Actually, they come to us after these procedures are being done. So, as I said, if patient is intubated and patient's relative or family, immediate family, they want to continue with the intubation, then definitely that process is again palliative. So we have to maintain their vitals and keep them as healthy as possible when it comes to hygiene. And same thing with tracheostomy. Tracheostomy, we take a different approach. We go for rehabilitation post tracheostomy. So where we try to involve speech therapist and where the swallow study can be done, and eventually the tracheostomy can be removed along with NG tube.
Okay. And in your opinion, how many patients or what percentage of patients actually survive palliative care and come out of it healthy?
Actually, unfortunately, what happens is people only, again, like there is very fine line between palliation and hospice. People usually come to us at the stage where they require hospice rather than palliation. Mostly palliative people, which comes to me, they're post-stroke. So yes, post-stroke surviving is pretty high, but then there is always a disability, residual disability, which they carry with their life or all of their life.
Hmm. Yeah, that's unfortunate actually. Yeah, so
Yes.
now talking about patients of stroke, that means now me being a psychiatrist, obviously I'll have this question in my mind that neuropsychiatry must be playing a very important role in this. So, what are the neuropsychiatric symptoms that you have seen in such patients? You know, patients of stroke and CKD and maybe with cardiac issues.
So again, the first part question, I couldn't hear it about the neuropsychiatry.
What are the neuropsychiatric symptoms that you come across in your patients of palliative care? You know, especially with
Okay,
the patients who had stroke.
right. So usually I see these patients with stroke or CKD usually see uh, suicidal tendency where they express their hopelessness of about life. Very often you see which repetitive. Very so often you see that indulge in self pity. They're not ready to accept that what they are going through or what their symptoms are or the whatever the disease condition is. These are some of the most common, and anxiety. In other words, these are some of the most common aspects which I see, especially when it comes to stroke and CKD patients.
Yes, and obviously there must be a lot of caregiver burden in such patients, right? So the
Yes.
caregivers must be constantly coming to you and bothering you with so many questions. You know, what is going to happen? What is going to happen with our patient? What is going to happen in the future? What are the medications the patient is? Also, how do you manage all that? You know, the caregiver burden.
So, being a chief care coordinator, my approach is always to have one meeting every week was the clinicians and the patient's relative or the patient themselves if they're cognitively alert. And understanding the barrier for future progression. Once I get those burdens lined up, then I have to approach appropriate professions to add those barriers. Say, for example, just like a person like a person with stroke, and if they're losing hope, they're getting depressed, and I hear that very often from that they're willing to eat, they're not willing to cooperate. Um, that's when a person like you, a psychiatrist, comes in the picture. Maybe pharmacologically, one of the interventions from you with a pharmacological intervention that might help. And if not, definitely a clinical psychologist who can, talk to them and what's going on actually, what is the thought process. So say for some people, I see post-stroke very so often as a neurogenic bladder. So neurogenic doesn't matter. I mean, needs to be addressed. So a neurosurgeon needs to be involved in that particular condition. That pharmacologically, non-pharmacologically, yes, we can teach them Kegel exercises and do what needs to be done. But pharmacologically, yes, a neurosurgeon needs to be involved. So that is how I address those issues, as many as I can, and try to make them feel more comfortable by adding quality years to your life.
So, how important is okay? There is a question. Are palliative care costs covered under normal Mediclaim policies in India? How expensive can palliative care get, and how to optimize the costs?
So, unfortunately, Indian insurance companies don't recognize palliation as a treatment option. Unfortunately, companies like Cigna, they recently started their operations in India. They recognize this, but that too after the fact that you pay then get reimbursed for it. And palliation can get a little on the expensive side, hence people don't opt for it. So, couple people in India who are doing actually palliation, they go for really basic palliation care where patients don't have to tolerate much of a financial, and certain things are not addressed at all, unfortunately. But that's the scenario right now.
Okay, I guess that answers that. Okay, now, so coming to your, oh, there is another question. I would like to set up a hospice care unit. Would like your opinion on how economically viable it is to set up such a unit.
So I have set up this unit. Really, I used to do that as outpatient basis where we would go to their houses and set it up. But recently, I've started inpatient unit for such patients because not many of the relatives can take in an agony which patient goes through when it comes to hospice. So when it comes to economic, seriously, I mean, I think that it is what it is. You know how expensive nursing care can get. You know how expensive the wipes, paraphernalia which you need to take care of those patients can get. Those are the major expenses which actually makes palliation a little bit on the expensive side. And if a person is, if the family is willing to pay for those, then well, it's pretty viable. But not many people in India are willing to pay for palliation or, for the matter, hospice.
Right. So, how important is physiotherapy's role in palliation?
Very, very important. Actually, not only physiotherapy, occupational therapy is another.
Yeah, yeah.
Not many people understand the difference between physical therapy and occupational therapy in India. How so that those two traits is basically physical therapists, they take care of mobility that is below the waistline, and occupational therapy, they take care of aerial activities or daily living that is above the waistline. So, especially when it comes to palliation, say a patient is suffering with cancer or stroke or CKD, the muscle mass is lost very so often. The strength is lost very so often. While walking, their gait is not right. Hence, they're using more energy and getting fatigue very so often. So, to address all these aspects, yeah, this paramedical services are very much needed when scoping and occupational therapy, and especially if patients, speech is involved with stroke. Yes, speech therapy as well, swallowing basically.
Am I visible? Okay. Am I visible to you, Dr. Ravi? Can you hear me?
Now I can hear you. Yes.
Okay, okay. Yeah. So also, I think we have almost, okay, thanks a lot, he says. He's actually an ENT
Well,
specialist. He is from Kolkata.
ah, nice meeting.
Yeah. So I think we have almost reached the end of our session, and we have asked a lot of questions related to palliation. But lastly, I would like to ask you as to how do you, it's just said, एक saying है कि जैसे हम psychiatrists को बोलते हैं, that seeing so much of depression and anxiety around you, you must be always depressed or anxious. Okay, so it's a myth. So similarly, just asking you, are there certain myths regarding palliative care doctors as well? Because you see so many deaths, you see so many end of life care patients, you see so much of grief around you, because of the comorbidities and also the actual disease and the caregiver burden, etc., etc. How does it affect your mental health, and how often do you have to take care of it?
So, yes, there is a myth which was long palliation and hospice that these people can smell death. I hear that very so often.
Wow.
Yeah.
Okay.
And then even families and friends asking me, आपको क्या लगता है कितना दिन है और कितना घंटा है, or this is the very common question. Yeah. Again, I tell them, I'm no God, so I can only make them feel comfortable. I'm nobody to decide what time they're gonna live, how long they're gonna live or when they're gonna leave the world. So, anyways, but yes, you are right. Looking at those
Yeah, so you
patients
must
and
have to answer them that I am not Yamraj, I am just a doctor. Yeah.
yes, you're right. But after looking these patients and patients' family dynamics, understanding them and seeing what they, I mean, it may be a financial aspect, it may be just a relationship dynamic with the patient. Sometimes I feel it's very unfortunate that a human being um, undergoes these kind of situation. Recently, I had this patient whose father was diagnosed with a CA stomach. Tumor was getting bigger, and we had to. I recommended to put a peg tube, or in jejunum, where they can, at least patient can be fed. Patient's kid was only 23-year-old, a working professional, but his aggression and his anger, though it was for the circumstances, but it was coming out of on patient. So sadly, you have to see
Hmm.
that, and somehow you have to counsel the relative that it's not patient's fault that they have this particular disease.
True.
So yes, it makes me think that how else these aspects of life can be addressed. How I keep up with it, the best way is to go and lift iron. That's for me. So you lift,
Mm-hmm.
you and you get your that's the best way I can recommend. Yes.
Yes, yes. So speaking about this, I had another question pop in my head. So, we
Uh-huh.
psychiatrists generally undergo this phenomena where a lot of caregivers just dump their patients, who are mostly in a psychotic phase, or, who are almost a burden to their family. And, their family has to listen to a lot of things because of those patients. And so they generally tend to dump them in our inpatient unit. They come, they admit them, they show care, and later on they do not even return to take the patient back. So does that also happen in palliative care much often?
Um, in my last 5 years over here in India, I have seen that twice where we were out of resources. Um, we did what we could. So eventually, we had to take that patient and admit it to the government medical college, where the patient's relatives were not answering the phone calls. Even the address, which was on their Aadhaar card or the address they gave us, was fake. So we had to take
Mm-hmm.
that patient in government setting. Yes, unfortunately, it happened twice, but it did happen. It does happen very so often. I've seen that in states as well. Older geriatric population patients will be admitted, and there won't be anybody to come and see them, meet them. But fortunately, in US, they have the system set up that now they become hospitals' responsibility. But here, being limited resources, we can only do so much. And
That's
GMC
so
and
true.
government medical college is the best place for them to go. At least the basic care can be done over there.
Yeah, even we have to shift such patients to, the regional mental hospital, where they actually keep patients and the funds come from the government and from the public taxes. And that's how their medications and their food and their clothing is funded. And also, then later on, they undergo occupational therapy. So, they are taught sewing, they are taught how to cook, they are taught a lot of other things, creative things and productive things, and then they
Right.
sell those things and then they get money out of it, and that is how the mental hospital works. So I guess, yeah,
Right.
the government is trying to put up certain firms and certain funds for such patients. So I think that is happening in palliative care as well in GMC and IGMC. That's very nice to
Yeah.
know. Okay. So, yes, we have reached the end of our session, and I hope the audience had a lot of information related to palliative care, which is not a topic that is discussed much. So, thank you, Dr. Ravi, for coming and enlightening all of us. And even a lot of doctors don't know what palliative care is. So, thank you very much for that. And also, yes, accepting our invitation in the first place.
Thanks for having me, and thanks for inviting me. If at all I could create a little bit of awareness about palliation and end of life care, that's my goal, and that's what I was trying to do. But thanks for giving me that chance to at least talk about it. Thank you.
Most welcome. And so that is what we do at Evrox Healthcare here. We try to bring in shows for public awareness. And now Evrox Healthcare is also recruiting doctors, nutritionists, other healthcare workers. So please, if you want to join in, please do. There is a phone number that will flash on the poster. You can definitely text on that, or you can visit our Facebook page or our YouTube page, subscribe, comment, and like there. Also, you can mention your names and how to contact you, or you can just contact on those available networks. And we will give you a demo of our F1 app in which you can actually understand how it works and how you can reach out to other patients from all over India. So, if you want us to cover more such topics of public awareness, which are mostly taboo, stigmatized, or not even that, please do comment. And thank you so much for attending tonight. Have a good night.
Thank you. Have a good night.